Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Dania Reynolds. In this episode, we focus on best practices for individualized care in transgender women living with HIV, including providing services in a gender-affirmative care model, proactive counseling on drug-drug interactions with gender-affirming hormone therapy, and strategies to reduce adverse events. To address these topics, I'm joined by Dr. Roger Bedimo from the VA North Texas Healthcare System and UT Southwestern Medical Center in Dallas, Texas. For more information about this program and to follow along with the slides, please visit the links in the show notes for this episode. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Now let's get started as Dr. Bedimo introduces a case.
This is a 41-year-old newly diagnosed transgender woman living with HIV. Past medical history is also significant for hypertension and smoking. That person has sex with men. They want to start ART as soon as possible, but is apprehensive about drug-drug interactions with gender-affirming hormone therapy. Current medications include oral estradiol, spironolactone, and amlodipine. You see the parameters here. This is somebody who's newly diagnosed, who doesn't have all the baseline labs available yet, and this is a rapid start setting. We have the CD4 count, we have the body mass index of 21, and normal liver function tests. And they're also immune to hepatitis B. Next is we have this is a call for awareness that transgender women living with HIV are less likely than cisgender men to receive antiretroviral therapy, to be adherent to antiretroviral therapy, and to achieve viral suppression. So we need to be very proactive to break the barriers to care for these transgender women, even more so than other people because of this fact. And there are a number of barriers. So lack of access to care, stigma, discrimination, housing instability, physical and emotional trauma, prioritization of other health issues, and then concerns about drug-drug interactions with gender-affirming hormone therapy. We need to be proactive in managing these transgender people, because if we're not, I always tell trainees that when a patient walks into your clinic, they can see in your face, in your attitude, in your mannerism, in all the setup in your clinic, whether you are putting them at ease, whether you're receptive to what type of people they are, and whether they should open up and tell you what they think is bothering them, or whether they should just humor you and tell you what they think you want to hear. You don't want to be the latter. You want to be a provider who puts the patient at ease and who is able to immediately put them at ease and break the barriers. The potential for interaction should not prohibit antiretroviral therapy, and data is clear on that. So, but it's important to allay the person's concerns about this by acting proactively, because they may be worried about that, and they may not tell you. The impact of this GHT on antiretroviral therapy, there's no clinical significance. And on the way around, the impact of antiretroviral therapy on those gender-affirming hormone therapy theoretically exists, especially maybe with protease inhibitors, but there's likely no clinical significance. And so INSTIs or integrase transfer inhibitors, the most used drugs now for initial antiretroviral therapy, have less potential to affect gender-affirming hormone therapy. So no adjustment is necessary. There is limited data for protease inhibitors, but the impact is unclear. They may decrease or increase concentrations of hormone, but the level of this impact is minimal. So we do not advise any change in regimen based on that. However, to put people at ease, it may be possible to monitor hormone concentrations. And again, those is based on desired clinical effect and the concentrations. So this is what the summary of the DHHS guidelines are, considerations for ART in transgender people. Essentially, treat like everybody else. That is the bottom line. So ART is recommended for all transgender people living with HIV. Provide services in a gender-affirmative care model, which is inclusive. Perform pregnancy tests for all those with childbearing potential, because pregnancy may affect the choice and monitoring of antiretrovirals. Monitor clinical effects and hormone effect in those receiving gender-affirming hormone therapy. And avoid regimens that increase the risk of cardiovascular disease and the risk of osteopenia, which are two things that may be associated with hormone therapy. So do not maximize that risk using antiretrovirals that may further it. For cardiovascular disease, we're probably talking mostly about boosted protease inhibitors. For osteopenia, we're probably talking mostly about tenofovir disoproxil fumarate. So provide services in a gender-affirmative care model. What does that mean for most? That the environment a patient walks into will set the tone for the visit and experience overall with a clinic or a care provider. So ensure that the staff are trained on basic cultural competency and humility, incorporate inclusive language and terminology. Be careful not to misgender people. Registration forms and EMRs should be inclusive of gender identities, and integrating hormone therapy with HIV services is recommended for people who can be proficient in that. If not possible, then refer to healthcare providers knowledgeable in the field of hormone therapy. As you can see here, these are the antiretroviral therapy recommendations for transgender people, are the same as for most people living with HIV, either in the DHHS guidelines on the left or the IAS USA on the right. And both guidelines bodies prioritize or treatment with integrase inhibitors-based regimens. The sole difference being that the IAS USA does not recommend dolutegravir, abacavir for most, while the DHHS guidelines does. The rest of the recommendations are identical. It is important to note that all available evidence indicates that there are improved clinical outcomes when we do rapid ART initiation. Now, this has come to the fore in the past 5 years or so, or even longer, and it's important that this same-day antiretroviral therapy be considered because it improves retention to care and viral suppression, and then just maybe survival in the long run. So we need to address that. And the only nuance when we using that rapid ART model is to know that we do not recommend regimens with agents that either have a low barrier to resistance or higher potential of transmitted drug resistance. I know we're talking mainly about NNRTI and 3TC or FTC, because those, it's a higher likelihood that people have transmitted resistance to that. So if you don't have the time to check for genotyping, it's not a safe thing. And of course, abacavir should not be used in rapid ART model because you don't have the time to test for susceptibility to hypersensitivity to abacavir. So that leaves you INSTI-based regimens with either TDF or TAF, as well as boosted darunavir with either TDF or TAF. That's what you can use in a rapid ART. So considerations to reduce adverse events in transgender women receiving ART: bone, heart, kidneys. And this is essentially the same thing I would tell you for people with any increased risk for susceptibility to dysfunction in those three organs, including postmenopausal women or older people. Bone first. TDF should be used with caution because bone metabolism may be influenced by sex hormone, and we know that TDF may increase the risk of osteopenia. Heart. We know that antiretrovirals containing boosted protease inhibitors and abacavir have been associated with increased risk of cardiovascular disease. So if you're already taking hormonal supplements that may heighten the risk of either hypertension, venous thromboembolism, or stroke, it's important to avoid those. The second thing is that tenofovir alafenamide may be associated with a higher risk of hyperlipidemia which means that you may want to also be careful that people with increased cardiovascular risk. Kidneys, gender-affirming hormone therapy can affect the estimates of EGFR, so they may not be as reliable, especially with people as they induce increased muscle mass. So that's just making you aware that the measurement may be a little bit challenging in those people. Revisiting the three things that we know people with who use gender-affirming hormone therapy have: less likely to initiate antiretroviral therapy, so rapid initiation is important. That's what we just visited. Second thing is less likely to be adherent, so affirming adherence importance and proactively addressing things that may limit adherence are important. So engaging in informative discussion about lack of meaningful impact of ART on gender-affirming hormone therapy is important. Measuring hormone levels and reviewing results in people who are concerned that may be useful to support their adherence. Patients should be reassured that once estradiol level is in the physiologic range, increasing levels higher than that will not enhance effects, may just enhance side effects. So take-home points for these transgender women care. All transgender persons living with HIV should receive antiretroviral therapy, number one, and should be considered for rapid start to improve retention. ART regimens recommended for most people are unlikely to significantly alter hormone concentrations, regardless of gender-affirming hormone therapy use. And gender-affirming hormone therapy is also unlikely to affect ART concentrations on the other direction of the equation. So hormone levels can be monitored and doses of GHT can be calibrated to physiologic levels until the desired effect is achieved. Also, proactively counseling patients to address concerns and fears of drug interactions is very important to improve adherence and persistence on ART.
Thank you very much to Dr. Bedimo, and thank you to our listeners for joining in. Get access to all of our new podcasts by subscribing to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.